Hello, my name is Dr. Bonnie Ky, and I'm Editor-in-Chief of JACC Cardio-Oncology. I'd like to welcome you all back to case number 2 on amyloidosis, and again, introduce to you our great panel, Dr. Witteles, Dr. Wilson Gonsalves, and Dr. Rola Khedraki. Dr. Khedraki, take it away.
So this case is that of a 69-year-old male who presents to his primary care with generalized weakness and numbness of his left leg and foot for the past 3 months. He has a history of basal cell carcinomas, malignant melanoma of the ear that's been treated, bilateral thumb carpometacarpal joint arthritis, rotator cuff tendinopathy, and lumbar radiculopathy. His mother had Alzheimer's, and otherwise his social history is unremarkable. So he's referred to neurology, and by this time he's had several falls due to gait imbalance. He's also complaining of sexual dysfunction. He has an MRI brain that's unremarkable, and an MRI of his back shows that he has a synovial cyst that's compressing his left L5 and S1 nerve roots. So he undergoes EMG and nerve conduction studies that show that he has an L5 S1 radiculopathy, and he's treated with steroid injections. Later, he's still having this persistent, now progressive, left lower extremity neuropathy. He's failed medical therapy, and now he's also starting to develop bilateral arm numbness and tingling. An MRI C-spine shows that he has multi-level cervical spondylosis and facet arthropathy. And ultimately, he's referred to neurosurgery for lumbar decompression and resection of the synovial cyst because his left lower extremity neuropathy is really the thing that's bothering him the most. So at his post-op visit, he has persistent symptoms of left lower extremity numbness. And the thought is maybe this is just from long-standing impingement. You know, it's going to take more time to recover, or perhaps this is permanent to a certain degree. And at the time of this visit, he's also complaining of some symptoms that are consistent with bilateral carpal tunnel, and he also describes some dysphagia. So he's referred back to his neurologist for consideration for repeat EMG and nerve conduction studies with the thought that maybe there's something more systemic going on given all of these complaints, either ALS or some other neuromuscular disorder. And so he sees his primary care first. He's 2 years out from his initial complaints. Now he's having progressive exercise intolerance. This is someone who at baseline was very active, was doing challenging hikes and swimming for a mile at a time, can barely do a lap in the pool now. And so he's referred for an echocardiogram to work that up further. And for his dysphagia and now weight loss, he's referred for a barium swallow. He's also describing that he's having bright red blood per rectum, and it's presumed that perhaps this is just hemorrhoidal bleeding. And so he finally goes to see his neurologist, and at this point he's complaining of shortness of breath, lower extremity edema. They don't even get a chance to talk about his neuro symptoms, and so an outpatient D-dimer is shown to be elevated, and he's referred into the ER for a CTA of the chest to rule out PE, which is negative. So I just want to pause here and maybe have you guys comment on what your thought process is as you think about this patient who's presenting with this constellation of symptoms.
Yeah. Thanks, Rola. So this case unfortunately highlights a frequent problem of patients who go through the system with multiple misdiagnoses. It's been seen with amyloidosis that people often get misdiagnosed in periods of either many months or often years before arriving at it. In this case, there were a few hints. The sensory and motor neurologic abnormalities that he had, ultimately GI bleeding, and then obviously the concomitant heart failure, the bilateral carpal tunnel, all of these things in hindsight, you look at it and say, oh gosh, these were some red flags. Now, this is a conference on amyloidosis, so I'm guessing that's where this is going. But I'll note that there are two types of amyloidosis that could lead to this. AL amyloidosis certainly can cause involvement of all those systems, but so could the variant or hereditary forms of transthyretin amyloidosis, whereas some mutations specifically go after the nerves and the heart. So both are still certainly possible here among the amyloidosis differential.
Absolutely. I think just looking at this case so far, I mean, can't make a diagnosis directly, but it's definitely not looking good the way things are progressing. But that second point, PCP, 2 years, some initial complaints, that is, I would say, an average case. I mean, it's kind of sad, but it roughly takes about almost 12 months before a patient with, at least this is data from AL amyloid, that would take them get diagnosed with that condition. And on average, somewhere between 3 to 4 different consultations with subspecialists. And I haven't kept tabs, but I think neurosurgery is on there, neurology on here, so that's already 3 different physicians. But once you look at all of these symptoms on there, and if you just in isolation looked at every one of the symptoms, it's really hard to kind of think of one global systemic disorder causing all of this. So sometimes you really need to see all of this on one slide to have that light bulb go off. But unfortunately, that doesn't happen in real life.
I think what you both are highlighting is a high index of suspicion that we should all be aware of. We see these patients in clinic all the time, and it likely does go under-recognized for a long period of time, but having a high index of suspicion when you see these constellation of symptoms sounds like one of the major teaching points here.
Absolutely. I think in my mind, if I was out in a primary care clinic, if there's one thing I could figure out, if out of the hundreds of patients I see, if there's one patient that comes to me with a history of bilateral carpal tunnel and otherwise doing fine and no real occupational reasons why they should have had bilateral carpal tunnel, at least that's the easiest thing you can at least start thinking of. Everything else is a little more complicated.
Yeah, absolutely. Kind of disturbing when you see all of this on one slide, like you said, but not an uncommon scenario. And it's really about having that high index of suspicion. So these are his labs at the time of his ER visit. His total protein is mildly decreased, some LDH elevation, and his NT-proBNP is elevated, and otherwise just a mild anemia. And his labs are otherwise unremarkable. Any thoughts on this before we move on to his EKG?
I think we can move on. Obviously, the high NT-BNP is notable, but I think we can move on.
So this was his EKG 3 years ago. Normal sinus rhythm, otherwise, pretty remarkable EKG. And this is his EKG at the time of his ER visit. Markedly changed. You can see low voltage, and he's got that pseudo-infarct pattern in the inferior leads that you were alluding to in the last case, Dr. Witteles. This is his echo. He's got, this pretty marked thickening. You can tell even in his parasternal long here, and here are his 4-chamber views. Sort of a biventricular thickening, again, thickening of the valves and biatrial enlargement. He's got mild to moderate to MR, and you can sort of appreciate how thick even his RV is in this subcostal view. And so we went on to obtain electrophoresis and immunofixation, and it showed that he had a faint monoclonal protein band, and this was consistent with either a free kappa light chain, IgD kappa, or IgE kappa monoclonal gammopathy. So, I'm sort of interested in your guys' thoughts on this so far, and whether the M spike or the amount of M protein sort of is helpful at all in sort of diagnosing in the diagnosis here.
So I would say that I would think of it in the context of AL amyloidosis, not myeloma, but in the context of AL amyloidosis as dichotomous. It is present or it is not present. You don't need a lot of the monoclonal protein present in the serum or the urine to have that as a potential diagnosis. And again, it can be a particularly sticky light chain that quickly deposits. Here we don't see a full immunoglobulin, but that's fine. There's plenty of plasma cell dyscrasias that will only produce light chain. So if you see any, you need to be concerned.
I look at this SPEP and sometimes it throws people off because on that monocle protein row at the very last it says less than 0.1, so people will ignore that and say it's trace, and they stop. You underline the text really well because for their immunofixation they see a kappa light chain by itself without an accompanying G, A, or M. To me, that just tells me one thing. It tells me that if you can see a kappa light chain on your immunofixation by itself, it's not a trace kappa light chain. Actually, that's one of the teaching points. You should always get light chains and not just the serum protein that decreases with immunofixation, because if your light chain is only mildly elevated, but as Ron said, your light chain is so amyloidogenic that it doesn't really get to a high level, your SPEP will be completely normal. Your immunofixation would say no monocle protein detected. So just with the fact that actually picking this up tells me there's more to the story than just this aspect.
Yeah, absolutely. This highlights that hypogammaglobulinemia doesn't really help you one way or the other, and the size of the M spike doesn't help you. So this is his UPEP, and it shows a monoclonal free kappa light chain immunoglobulin as well as Bence-Jones proteinuria. I've included his UA here and his protein albumin, his protein creatinine ratio.
And so just to be clear, Bence-Jones proteinuria is the detection of the monoclonal light chains. That's what it is. And the reason for getting the UPEP or UPEP with immunofixation is because light chains are concentrated in the urine, and you can find that monoclonal spike there. The truth of the matter is that with an serum protein electrophoresis with immunofixation, which is mainly looking for the monoclonal immunoglobulins, and a normal serum-free light chain ratio, the likelihood of finding a monoclonal protein on the urine in the urine is quite low. For completeness, we would generally recommend all three. But the point that Wilson made cannot be emphasized enough. A normal, which this one wasn't, but a normal serum protein electrophoresis with immunofixation alone is not enough because you won't pick up low-level monoclonal light chain abnormalities.
Just by looking at this UPEP here, your fourth row monoclonal protein with it's just giving a percentage, so that 80% of the protein they're detecting in there are the monoclonal free kappa light chains. That's telling you something. You probably have a significant light chain level.
Right. And at this point, this was his light chain ratio markedly elevated. So just emphasizes the point. It's really important to obtain all of these sort of in conjunction with each other. He did undergo a pyrophosphate scan as well, and this was sort of equivocal, showed mild grade 1 uptake, and his heart to contralateral lung ratio was 1.2. So overall, just an equivocal scan.
So I just want to make the point that, and again, I realize for practicality reasons, sometimes these are all ordered at the same time. But this is an inappropriate test. Ideally, this never would have been done because once you see the monoclonal protein present, again, you cannot use this test to make any diagnosis. So even had the test looked clearly quote unquote positive or clearly quote unquote negative, it wouldn't have meant anything.
Right. Yeah. And again, it's just sort of concomitant workup, but highlights that now you can't use the pyrophosphate scan anymore now that you've got this abnormal UPEP. So his bone marrow biopsy showed that he has a plasma cell myeloma comprising 70 to 80% of the marrow. The immunohistochemistry showed that these cells express CD138 and kappa light chain. The flow cytometry showed a kappa light chain restricted plasma cells, mostly positive for CD38. And the FISH showed a monosomy 13 and a translocation of 1114. Bone marrow biopsy was stained with Congo red and was negative for amyloid. So do you guys want to comment on these bone marrow findings?
Yeah, just looking at that first line, 70 to 80% of his marrow with clonal plasma cells. That's not necessarily a good finding. One, he definitely meets the criteria for multiple myeloma. But with all this previous history and everything that he's presented with, especially with his echocardiograms of his heart, your concern is, does he have concurrent myeloma with a, depending on what the amyloid deposits could find them. Does he have AL amyloid with myeloma? These high light chains of over 200 milligrams per deciliter fits the fact that he has close to packed bone marrow here. And then he cytogenetic studies show that he has this T1114 chromosome abnormality, where a portion of the 11th chromosome is swapped with the 14th chromosome and vice versa. And that really is a classical signature in about 50% of AL amyloids. So when you see that, this is not uncommon. Whereas in multiple myelomas, they tend to be in the order of 15 to 20%.
And I'll just highlight that the lack of finding the amyloid deposits on the bone marrow, again, I would ignore. If you find it, great. You're fortunate enough to find it, you can make the diagnosis, but that should in no way dissuade you from pursuing a diagnosis of AL amyloidosis in this patient.
There's no tricking you guys. So this was his abdominal fat pad biopsy that is stained with Congo red and shows this pinkish material, again, that is consistent with amyloid fibrils. So, as you alluded to, Dr. Witteles, that, it's not surprising that we didn't find it in the bone marrow. So sometimes you can miss amyloid on the Congo red there, and you still have to look for other signs, other tissue biopsies.
Yeah, I mean, I'd say, a couple of things in this case. So one, one could have made a case that he has a clear treatment indication for his myeloma. So it doesn't matter that much if you make a diagnosis of amyloidosis, and that's not totally unreasonable. There's probably some subtleties ultimately, but number two, one could have just assumed he has AL amyloidosis based on the cardiac findings and the fact that, again, you don't have to make an absolute diagnosis because he already has a treatment indication for his myeloma. Three, in terms of where to go for another biopsy, the fat pad or elsewhere, there will be some institutional variation with this. I suspect at Wilson's institution, this is exactly what he would have gotten with an abdominal fat pad biopsy. At our institution, if we were going to pursue it, we would have almost certainly done an endomyocardial biopsy. Again, I think there's reasonable differences in practice patterns. The thing about a fat pad biopsy that you have to remember is that there is still a substantial false negative rate, particularly in institutions that don't do it as much, and certainly in transthyretin amyloidosis, which is not a concern here. So if you do a fat pad biopsy, that's fine, as long as you're committed to moving on to the next step of biopsying a clinically involved organ if it comes back negative. Here it came back positive, and so that you could confirm the diagnosis.
Yeah.
Of course, I'll just point out it needs to be subtyped, even though we're making the assumption that this is AL amyloidosis. Again, he could have myeloma plus transthyretin, as we saw in our last patient. Unlikely, but you'd want to, for completeness, subtype it.
Right.
So what we would do is, with the bone marrow biopsy, we were highly suspicious for AL amyloidosis, or we're looking at amyloidosis. We'd get the fat pad biopsy and the bone marrow biopsy. And at least our numbers would kind of suggest that we probably pick up about 85% of the cases that way. But that still means that, you have a 15% chance that both of those would be negative. And that by itself does not mean you should stop there and this is not AL amyloid. And I think that sometimes gets dropped outside. So that's important to recognize. I mean, personally, I'm pulling my hair if both of these are negative, because I really just want to make the diagnosis quickly. But no, if this abdominal fat pad was negative, this would be a stat referral to our cardiology colleagues, and they would take him immediately the next day for an endomyocardial biopsy. And remember, if you biopsy the organ that you have a very high suspicion of, if it's the heart or kidney or so forth, the chances are close to 100% you'll probably find it.
Okay, so this is the cardiac staging system for AL amyloid. It's got the original Mayo Clinic staging system as well as the revised one, which is the most widely used now. And by this, he's sort of a stage 4, which, based on his NT-proBNP, his troponin elevation, and the difference between involved and uninvolved free light chain ratio, free light chains. And so by this, his median survival is about 6 months.
Can I just make just jump in for one? Was his troponin that high? I thought his troponin wasn't, but maybe I misremembered that. But
it was elevated. Yeah.
Okay, I'm not sure if it was above the threshold, but most importantly, I'll point out. So you can see how the median survival improved between those top two. And that's not because of anything other than vast improvements in light chain lowering therapy options. But what I want to point out is that even the second one, which was published out of Mayo in 2012, by now is out of date because light chain therapy options have gotten so much better since then. So 2 recent reports, one out of Boston University, one out of Stanford, both suggested similar numbers, which now shows that for stage 2 patients, you're probably talking about a 60% or so 10-year survival. And for stage 3 patients, you're probably talking about a 5-year survival. So just massively different than what was here. It is those stage 4 patients, though, who still struggle the most with, even in the contemporary series, anywhere from sort of 6 to 12-month median survivals.
Perfect. Can you comment on, is this the staging system we should be using, or is there any role for using the revised international staging system?
There's different staging systems that are used. So like the Boston University one differs from Mayo. The one that we used at Stanford was the Mayo one. What I would say, at least in our cohort, we found that the difference in free light chains that 180 milligram per liter or 18 milligram per deciliter, as some labs use, cutoff, that it actually seemed to, in our data set at least, it was the people with the really low light chains, the difference of less than 50 milligrams per liter or 5 milligrams per deciliter, who had the better prognosis. And above that, it didn't matter as much. The NT-proBNP or BNP, whichever your lab preference is, the troponin T or troponin, whatever your lab preference are, those still have major prognostic significance. Again, you can have slightly different criteria, but they all send the same message. The worse the cardiac involvement, the worse the outcome. But number 2, that outcomes have vastly improved over the last decade because light chain therapy has gotten so much better.
That's absolutely correct. That second staging system, the revised Mayo Clinic staging system. So that was back in 2012, published in JCO. And so you can think about the therapies we had, in the early 2000s. A lot of them revolved around old school melphalan and dexamethasone, and just starting the use of bortezomib at that time. So you're absolutely right. These numbers have improved in recent years. The other thing that just by glancing at all this, the first thing that screams out of how difficult the situation can be is if you have myeloma with concurrent AL amyloidosis, that in itself, I know it's not included in any of the staging systems just because it's not that common, but this patient clearly has it. That high plasma cell burden, the outcomes tend to be much poorer. And then finally, I think the other key thing is that treatments are always changing. Our standards of care are always changing, and I think in the next few years we'll be changing to other therapies too that probably deepen your response upfront at a much sooner time point. And so these numbers will always keep moving, which is a good thing. You want these numbers to keep going upwards, but staging systems are there to be revised every few years.
Thank you for that. So for this patient, he was started on Cyber-D, and I just want to show you his light chains 2 weeks later. Is this what you would consider an appropriate response after starting therapy? And what are you looking for? What are your goals with treatment?
From a hematological standpoint, the sooner you can get the light chains down, the better. You know, it's not just the amyloid deposits that are already there and causing cardiac dysfunction and so forth. These light chains themselves are toxic in itself to the heart. And so, you know, the more rapidly you can reduce these light chains, the better. That being said, in 2 weeks, 283 down to 143, so roughly about 50%, close to, in about you know, half a cycle, or Cyber-D regimens typically every 4 weeks or 2 weeks. You've got that's, you know, I would say that it is it's on track. When would I change therapy, or when would I be concerned? If it hasn't budged by the end of one cycle, absolutely. A lot of people outside would put this line in the sand, draw this line in the sand, saying that if you haven't dropped by 50% after at least 2 cycles, then you absolutely should change therapy. I think I would be, you know, if somebody was as sick as this, I would be even more aggressive. And if you didn't budge much with the first cycle, I'm not going to give you that second cycle and wait an extra 4 weeks to, you know, think that, you know, a different month is going to make things better or so. So yeah, you know, everyone practices it very differently, but almost everyone would agree, at least from a hematology standpoint, that if you don't drop your light chains by at least 50% at the end of 2 cycles, we really should move on to something else.
Okay, so a favorable hematologic response here. So at that sort of 2-week mark, he comes back to heart failure clinic, and now he's complaining of syncopal episodes, few near syncopal events, and again, this bright red blood per rectum. And this is his EKG showing frequent ventricular ectopy. He's admitted to the hospital, and this is his set of labs. And sorry, Dr. Witteles, I think in my mind, I had already jumped to his troponin being elevated, which you can see here at this ER visit. His LDH is higher, albumin, total protein are lower, and otherwise his CBC is still stable with that mild anemia.
This is exactly what I read looking at those labs. And was this in 2 weeks when you saw him back?
Yeah, this is at that 2 weeks. Mm-hmm. So while he was being monitored, he actually had another pre-syncopal event. He was noted to have complete heart block. He was transferred to the ICU, and you can see he's got a junctional rhythm that you can better appreciate maybe on this 12 lead. Dr. Witteles, can you comment a little bit on pacemaker ICD therapy in a patient like this?
Yeah, so, you know, the pacemaker indication is much more straightforward. If somebody has symptomatic bradycardia, then assuming it's within their overall goals of care, then they need a pacemaker. Defibrillator is much more difficult question to answer. The old thinking in AL amyloidosis was generally to avoid them, largely because by the time you put in defibrillator, by the time people's heart failure was bad enough, they had arrhythmias, particularly in an era where light chain control wasn't very good. The thinking was you just be converting a peaceful sudden death to a sort of gruesome heart failure with a bunch of shocks as their dying death. And that can still be true if you pick your patients poorly. I would say I'd be worried in this patient who has lots of reasons to be exceptionally concerned of a very limited life expectancy, of whether ICD placement would be appropriate. That being said, assuming it's within his goals of care, he clearly has an indication for a pacemaker, and now you're saying, well, as long as I'm going to put it in, maybe I'm going to put a defibrillator in. So you'd have the discussions with him on that. I would say that the other consideration is if you're going to be putting in a pacemaker and his heart failure is this bad, are you going to put in a BiV pacemaker given that the indication is heart block? And though there's not great data from this on this, there's one paper that looked at this that showed clearly NT-proBNP at least doing better with BiV pacing. And I would say if I were to do it, I would definitely put in a BiV pacer in him, and depending on his goals of care, arguably a BiV ICD. In patients who are less sick than this, who have AL amyloidosis and ventricular arrhythmias, I absolutely personally believe that ICDs are appropriate. So this is a tougher one because of his prognosis.
I think that's fair. So based on our goals of care discussions with him and our multidisciplinary meetings, we decided to proceed with pacemaker implant. And as he was being prepped for the pacemaker, he actually had acute bradycardia and asystole. Transcutaneous pacing was attempted, and he had intermittent capture but no pulse. And at this point, an emergent transvenous pacer was placed, again, electrical capture but no pulse. And unfortunately, his rhythm degenerated into VT-VF. He was placed on ECMO, and a few days later, he was transitioned to comfort just from inability to wean and his sort of long-term prognosis. So I'm going to move on to the learning points here. First and foremost, AL amyloidosis is rapidly progressive. This is a very different sort of beast from TTR amyloid, like what we saw in our first case. And there is an association with plasma cell dyscrasias. The prognosis is really dependent on the degree of organ involvement, and cardiac involvement is certainly associated with the worst prognosis. And it's important to be aware of the extracardiac manifestations. You know, this patient who initially presented with predominantly neuro complaints and then some GI involvement as well with his hematochezia and dysphagia and whatnot. So, and it's important in cardiac amyloid that if it's suspected, that you always obtain SPEP UPEP-free light chains. A pyrophosphate scan is certainly not enough. I think we've definitely highlighted that point with these two cases. And just want to highlight this algorithm. You know, when you're on this side of the algorithm and you've got abnormal SPEP and free light chains, then your next step is that you want to obtain tissue biopsy. Actually, in this patient, he deteriorated so quickly that we, you know, obviously we had the fat pad and like you had said, sort of arguable if you really need the cardiac biopsy, but he deteriorated so quickly that we never even had a chance. And I think that really highlights just how rapidly progressive it is and how important it is that we not miss this diagnosis.
Just say he wouldn't have needed a cardiac biopsy. Once you have a tissue diagnosis of amyloidosis, then you can generally use the clinical findings to say what organs are involved. In his case, he had a tissue diagnosis off of his abdominal fat bed biopsy, and he had the clear cardiac involvement.
Yeah. So this case clearly highlights the importance of early diagnosis. I mean, this no matter what therapy you have, CyBorD is a really good regimen. Bortezomib, being a proteasome inhibitor, can rapidly reduce light chain, but if you're starting off at a very low point, it's going to be really hard to come out of it, which is exactly what this case kind of points to. And you know, the fact that to the point where AL amyloid can rapidly progress, but this patient was also in the works for a diagnosis for several months to a few years. Unfortunately, even I think we've looked at a series, even up to 2015 or 2016, the early mortality within 6 months is roughly, I'll say about 20 to 25% still. You know, and that's, and I always take it with a grain of salt because we're taking, you know, a tertiary referral center and how many of patients are out in the community that are not making it that diagnosis. The one thing I just want to highlight, one last point is, so if I was seeing this patient and I was starting them on CyBorD, I'm always working really closely with you guys in the cardiac amyloid field. It's just absolutely imperative. You know, my biggest concern is you start them on CyBorD, that D stands for dexamethasone. Any amount of dexamethasone. The traditional dose is about 40 milligrams once a week. And a dose like that, just throw them into rampant amount of fluid retention and heart failure, and they start spiraling down. So I can't tell you how helpful it is to follow them. It's a little bit of hand holding. I feel like our cardiac amyloid colleagues really hold our hands as we treat them with this and get them through these congestive heart failure exacerbations. But even then, it's still hard. We still lose patients. And finally, this is the last point on this case, just because from a hematological standpoint, when I'm seeing the patient, we made the diagnosis. Really, with an eyeball test, just looking at one slide of all the labs, I need to make that call as to, is this patient somebody I would do conventional outpatient lower dose chemotherapy like Cyborg-E? Would I be thinking of doing a high dose chemotherapy like Melphalan in terms of an autologous stem cell transplant? And just with this case, looking at how high that NT-proBNP was and how symptomatic this patient was, I would definitely pick Cyborg.
That's absolutely terrific. I want to thank all of you. I want to thank you, Ron, Wilson, Rola, for this really excellent high-yield learning and teaching case presentation. And to our community, JACC Cardio-Oncology community, I really hope you found this discussion as important and as helpful as I did. Thank you.